cancer, epidemiology, and molecular pathology. I've been humbled and honored to be performing molecular testing for metastatic colorectal cancer in Singapore for the last 10 years. And I would like to share some of the experiences gleaned from my clinical experience with all of you today, because I'm sure probably all of you know someone, a colleague, a family member who has been afflicted by this terrible disease, which affects paupers as well as presidents. So before I start, here are some of my disclosures. Father and our mother really play a huge role in determining how we actually turn out in life. Of course, some people argue that nature versus nurture, the environment is equally important. But for the purposes of today's talk, take it that our genetic code, which resides in our DNA, has to be transcribed into a messenger called RNA through this process of transcription before this RNA message can leave the nucleus of the cell into the cytoplasm, where proteins are manufactured according to these exact instructions. And a cancer cell is derived from our very own cells. And sometimes this message in the DNA is garbled in a cancer, which is why it happens. And we can use various clinical laboratory tests to measure what some of these differences might be. So one of my experiences in the process of training to be who I am today is to be able to integrate all of the information from all these tests, starting from the gross pathology to the microscopic pathology to the performance of protein labeling antibodies, which is called immunohistochemistry or immunocytochemistry. And this is used for tests like HER2 expression in breast cancer and colorectal cancer, as well as gastric cancer. I also am able to count copy number changes when these genes are amplified by a cancer stem cell in order to enhance its own survivability in a hostile immune environment inside our bodies. And I also read into the genes using PCR tests, which is like what we do for COVID-19 now. RT-PCR for COVID RNA is a type of PCR test, as well as reading into the genetic code. And this practice of integrating all this information to formulate the treatment plan for our patients, it's called integromics, in which all of this becomes one single coherent diagnostic opinion. And I feel that this is best provided by people such as myself, who can combine the traditional as well as the molecular pathological knowledge of the disease process. So all cancers of the colon begin in something called a polyp. And this is something which I teach to the year 2 medical students, and I continue doing so even now in private practice. So basically, a polyp is a fleshy growth that arises from the mucosa of the large bowel. And it can either have a stalk, in which case it is called a pedunculated adenoma, or for the most of them, they don't have a stalk at all. And this is called a sessile adenoma. And genetic changes that take place cause these adenomas to form. And these genetic changes are in the cells that are lining the intestinal crypts. So many years ago, even when some of us were still medical students, there was this hypothesis called the Adenoma-carcinoma sequence that was formulated by a scientist and a clinician by the name of Vogelstein. So basically, for the vast majority of colorectal cancers that you may know of out there, 80 to 85% of them will be what we call microsatellite stable, or capital MSS colorectal cancers. So when I say MSS colorectal cancer, I'm in fact referring to the barn door colorectal cancers, that if you throw a stone out there in a ward full of colorectal cancer patients, you're going to hit most of them who have this hypothesized sequence of genetic changes occurring in the lining of their colon, the crypt lining of their colon. In most of us who do not have an inherited colorectal cancer in which a faulty APC gene is passed down from either parent and we are carriers of that faulty gene, the APC gene has to be lost, has to be deleted away from the genome of our normal crypt cells before the crypt cells start proliferating in a way that is out of control and out of measure with the rest of the normal crypt cells. Then an early change called mutation of KRAS, or Kirsten-Rouse sarcoma-associated virus gene, will transform this hyperproliferative epithelium into an early adenoma. And then there's this loss of 18q, which is called deleted colon cancer, which will cause the adenoma to jump from a low-grade to a high-grade dysplasia before it finally becomes a carcinoma when it loses the sentinel of the genome. A guardian gene called p53 is mutated or has lost its function, and then it becomes a full-fledged carcinoma. When further events such as amplification of a gene called PRL3 occur, the carcinoma learns to invade its way out of the colon, spread to the lymph nodes, liver, lungs, brain, and the peritoneum. And this is the typical behavior and its underlying genetic basis. So a sequential accumulation of mutation drives the formation of metastatic colorectal cancer from epithelium through polyp, through early cancer, through advanced and metastatic cancer. This occurs 85% of the time. Now, most of us who know of someone with colorectal cancer will probably be of the sporadic type, which affects about 80% of all colorectal cancers. In other words, there is no hereditary basis for having colorectal cancer. Faulty genes were not passed down to us by either of our parents to predispose us from developing colorectal cancer. But in about 20 to 25% of the time, something that our parents gave us might be able to be fingered as the reason why we might be getting colorectal cancer and getting it earlier than the rest of the general population who are also at risk of colorectal cancer. If the genetic basis is known, then we call it hereditary colon cancers, and that makes up about maybe 10% or 15% of all colon cancers. If there is a family history of colon cancer, but despite extensive genetic testing to date, we cannot uncover a cause or a reason to be at risk of colon cancer, then we call that familial colorectal cancer, in which the risk is increased by at least twofold, but no known genetic basis exists to date, which may then be discovered, so some sporadics may actually be containing yet undiscovered hereditary cancer variants, and they'll be reclassified here, and someday this part of the pie may also be reclassified as a hereditary cancer syndrome. So as you can see, LYNCH syndrome here, which is this yellow slice of the pie, is the commonest hereditary colorectal cancers, accounting for about a third of all hereditary colorectal cancers, and FAP is somewhere in there, maybe about 1 to 2%. So FAP is not the commonest hereditary colorectal cancer syndrome. LYNCH syndrome is. LYNCH syndrome was also known as hereditary non-polyposis colorectal cancer. But now it's named after Henry Lynch, who just passed away recently, and we've used this term, the LYNCH syndrome, in addressing it. So LYNCH syndrome is the commonest, and there are a couple of other colorectal cancer syndromes that may or may not be associated with the formation of excessive polyps in our colon. So classic FAP is here, and we know that either APC gene mutations that are inherited from our parents or biallelic faulty genes from both parents in this gene, which is responsible for DNA repair called MUTI, can cause a classic FAP phenotype in which you have thousands or tens of thousands of adenomas carpeting your colon by the time you're in the early teens. In the weakened form of FAP, you may get fewer polyps, and the gene mutations are different, but they may also involve the APC or the MUTI gene. Most of you might have heard of Peutz-Jeghers syndrome or PJS, juvenile polyposis syndrome or JPS, and a very recently discovered entity called polymerase proofreading associated polyposis or PPAP. Now, there was a song by this Japanese rapper called Pico Taro a couple of years ago of Pine, Pineapple, Apple, Pen, and that has the same acronym as PPAP. And this was only discovered within the last 5 years. And of course, Concordance syndrome can also cause colorectal cancer, as well as increased risk of breast cancer and thyroid cancer, as well as endometrial cancer. But for today's talk, I'm not going to touch on any of these entities. We are going to focus on LYNCH syndrome because something very exciting happened in 2017 which will change the clinical history of patients with LYNCH syndrome with metastatic cancer forever, and this is going to be the subject of my talk. So all these pathways, such as the pathway that I just shared with you, can cause a normal mucosa on top to become a colorectal cancer and eventually a metastatic colorectal cancer. So FAP patients and LYNCH syndrome patients are somewhere in the middle. So they proceed from normal mucosa through to metastatic cancer through what we call LYNCH pathways and FAP pathways. So it's slightly different from the rest of us who have conventional pathways as well as serrated pathways. Serrated pathways are thought to arise from a certain kind of polyp called a serrated polyp. So if you receive a report from your endoscopist and it says serrated adenoma or serrated polyp, pay attention, because some of these could be associated with an increased risk of developing colorectal cancer earlier than a general population who just has a routine tubulovillous or villous adenomas. And this is an example of a serrated polyp becoming an invasive cancer here. So the polyp looks like a sawtooth, kind of like a chainsaw. And then in a portion of the polyp, additional genetic changes happen to cause the epithelium to transform from high-grade dysplasia to frankly invasive carcinoma. And this is going through to the muscle coat of the colon already. In Lynch syndrome, patients may be predisposed to developing multiple synchronous and metachronous colorectal cancers. And as a result, once a diagnosis is made, some people actually get offered a prophylactic subtotal colectomy to prevent another cancer from subsequently arising in the colon with this field genetic change. So Lynch syndrome is inherited in an autosomal dominant fashion. Now, what does that mean? It means that as long as either one of our parents passes on a faulty gene in one of these 4 proteins, whose genetic names are MLH1, MSH2, MSH6, or PMS2, which are located on different chromosomes within our somatic cells, we have almost a 70% chance of getting early cancer sometime in our lifetime. And we should always take this to note when we take a clinical history for a family history of cancer occurring in our extended family. So most often, the culprits are MLH1 and MSH2. So mutations in these 2 genes will lead to an increased likelihood of developing colon cancer early in our adult life, sometime before the middle age or around thereabouts. So these 4 proteins have an interesting role to play. So this diagram here shows a stretch of DNA in which there's a mistake during the replication of DNA, causing a G or guanine to bind to a thymine instead of an adenine to a thymine. So these MSH2 and 6, what they happen is that they dimerize. These 2 proteins join together like partners. The partners slide along the DNA, and when there's a mistake in the replication of DNA causing a mutation like a G to a T, this protein will stay there, it will metabolize ATP, and it will summon the other 2 proteins, MLH1 and PMS2, to bind to it to form a tetramer complex. And there are more proteins in this complex than a tetramer, and it will try to repair this so that the mutation does not run amok and get propagated into more cells, and we do not then develop cancer. But in the Lynch patient, this fella is faulty. One faulty copy is inherited from either parent. So that's called the first hit. Sometime in your 30s, if you kena a second hit, and the second copy, say from the other normal parent, gets lost by the cell, it gets deleted, the cell somehow loses a normal functioning copy, then only the malfunctioning copy of these proteins, any of these 4 proteins, will exist, and then this mutation cannot be repaired, and then your colonic mucosa starts going haywire, and you start developing polyps, and you start developing cancer early on in life. So sometimes an inherited Lynch syndrome is not the only way that this MLH1 protein can misbehave. For some of us, although we do not have a family history of Lynch syndrome, we can still get a microsatellite unstable or MSI high cancer, which has a lot of mutations, because our MLH1 expression of the MLH1 protein can be subjugated and can be shut down by the cancer cell by this mechanism called promoter hypermethylation. And that frequently happens when we have what I showed you earlier a couple of slides ago called the serrated polyp pathway, in which the promoter of MLH1 gets shut down, the MLH1 PMS2 complex cannot form, and these errors in the replication of a DNA go uncorrected and start accumulating in the cell. These polyps also have a concurrent mutation in another gene called BRAF, and that mutation occurs in 40% of patients with this MLH1 promoter methylation, and it's called a V600E mutation. The 600 amino acid in the BRAF protein has transformed from a valine to a glutamine. So therefore, the presence of this mutation can be used to rule out the Lynch syndrome in patients who have this MLH1 promoter issues. So microsatellite high cancers occur 15% of the time. So remember I said earlier that microsatellite stable cancers, or MSS cancers, are responsible for 85% of the colorectal cancers that are diagnosed. So what about the other 15%? You know from the pie chart that about 5% of them are due to microsatellite instability. And these are called MSI cancers, or microsatellite high cancers, or deficient MMR cancers. The two terms mean the same thing. And they also affect extracolonic sites such as the brain, in which you get increased risk of developing glioblastoma. You may get increased risk of developing small cell lung cancer, liver cancer, pancreatic cancer, small intestinal adenocarcinoma, prostate cancer, thyroid cancer, breast cancer, other GI or biliary tract cancers, as well as certain sarcomas, endometrial cancer, and cervical cancer. So LYNCH syndrome is by no means a disease that only causes colorectal cancer. In 2017, something very unusual happened. An antibody called Keytruda, real name is pembrolizumab, was approved by the FDA for patients with a stage 4 cancer that had this mismatch repair deficient or MSI high phenotype. In other words, the cancers behave as though they were from patients with LYNCH syndrome. Maybe some of them had methylation of MLH1, but maybe a fifth of them were actually LYNCH syndrome patients. The response to the injection of this antibody was a whopping almost 80% back then. And for patients who did not have this MMR, if you gave them this drug, this monoclonal antibody, to block a certain protein on the surface of the cell, the response rate was a paltry 11%. It's almost an 8-fold difference in the response rate. So my demand for testing for MMR went sky high through the roof for the last 5 years. And this is the first time the FDA approved a drug for the treatment of any solid cancer based on a genetic feature and did not depend on the type of cancer. It was not just approved for colon, but thyroid, lung, so on and so forth. Any other cancer in the body that had association with the extracolonic LYNCH syndrome would probably get an approval and a chance to use this drug. So this was in 2017, and another drug very quickly followed later in the same year for both adult and pediatric cancer. And so this test, which many of you are actually ordering in the hospital setting. So GPs may probably be just nice for you to hear about this, but a lot of surgeons who operate on the bowel or on some extracolonic cancers actually end up ordering the immunohistochemistry test for the loss of any of these 4 proteins, as well as a PCR test, just like a COVID test, to detect instability of the microsatellites brought about by the malfunctioning of these same 4 proteins. So there are 2 ways you can skin the cat, either through a PCR test or a protein test, PCR or protein, but they both are supposed to show almost the same thing. So this is a colon cancer in a patient who has a concurrent loss of MLH1 and PMS2. So you can see that there are a lot of lymphocytes in the background that are staining positive. They look like sesame seeds and they are brown, but in the cancer cells, there's loss of staining. Whereas for MSH2 and 6, expression is preserved because you can see the cancer cell nuclei here, where my red arrow is, still showing expression of MSH2 and MSH6 protein in the nucleus of the cell, where they are going about checking the DNA of the cell. But these 2 cells have lost the ability to express the protein that allows them to check for errors in the DNA. It's gone. So there's co-loss of PMS2 and MSH1. So these are the ways in which these 4 proteins can be lost. So in a normal MSS or proficient MMR cancer, when you order these 4 proteins or the mismatch repair test, all of them are expressed in the cancer cell. You can see the arrow here. The nuclei, which is this sesame seed thingy, which is outlining the shape of a gland, is actually the nucleus of the cancer cell. It is brown, 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 and brown for all 4 of these markers. Like the earlier case I showed you, when you lose MLH1 and PMS2 at the same time, there is a loss of these 2, but MSH2 and 6 are preserved. You can only lose PMS2, you can lose both MSH2 and 6, or you can only lose MSH6. So these are the 4 patterns in which you can diagnose a positive LYNCH case or a sporadic MSI high colorectal cancer by means of the protein test, which is immunohistochemistry, using an antibody to label these 4 proteins in the nucleus of the cell. So this is how it's reported in the pathology report. So you can also use PCR to show what happens when these 4 proteins are malfunctioning. You get allelic imbalances in what we call microsatellites, which are non-coding or so-called junk DNA, in which there's a lot of repeats of AAAAA 100 times to 150 times in between the genetic coding regions of our genome. So this is a microsatellite unstable in which there's a smaller allele, and normally small allele for this number of repeats caused by a faulty function of the 4 proteins that I mentioned in the earlier slide. So it's now available as a 2-hour test on this cartridge called the IDELA MSI assay. So all I need to do is to take a paraffin section from a surgically resected sample or endoscopic biopsy of a colon cancer. I load it into the cartridge, put the cartridge in the machine on this loading tray. 2.5 hours later, I will know whether the microsatellites are unstable or stable. And then that will affect the decision of the oncologist like Dr. Fu in determining whether or not he can give pembrolizumab monoclonal antibody in the treatment of a stage 4 colorectal cancer patient. So there is a relationship between microsatellite instability and the number of mutations, as I alluded to, when any of these type of proteins is malfunctioning in the cell. There tends to be a much higher number of mutations in the genome per 10 to the power of 6 bases of the genome that one can sequence on the next generation sequencing platform. And the consequence of this having many mutations is that many novel proteins with neoantigens are created because of this infidelity of the microsatellites and the inability of the cancer cell to repair its own genome. So these proteins do not exist in the normal cell because the normal cell won't have all these mutations. So this causes the immune system to seek out and attempt to destroy the cancer cell. And when we give an antibody such as pembrolizumab, we actually block the ability of the cancer cell to stop the T cell from attacking it by expressing this protein on the cell surface called PD-L1. So when a CD8 T cell comes and wants to destroy this protein, this foreign protein which is present on the surface of the cell, the tumor cell tries to protect itself by causing PD-L1 to come up to activate the PD-1 receptor on the cytotoxic T cell. So what that drug does is that it blocks this interaction and allows the T cell to kill the cancer cell. And this is why this drug works. So in patients who do not have this MSI phenotype or have this MSI phenotype, we call them deficient or proficient in MMR. In MMR proficient tumors, you hardly see any T cells, in the tumor and the stroma. And PD-L1 tends not to be expressed. When there's a deficiency, there tends to be an increase in PD-1 expression by the T cells, as well as an increased number of T cells within the cancer. So basically, there are many tests that we can do. That was an example of an immunohistochemistry test, this brown labeling of T cells of PD-L1 on the surface of the cancer cell. Some other tests that are of interest to surgeons and oncologists include HER2 testing. This is a colorectal cancer with 0, 1+, 2+, and 3+ HER2 expression. And we do FISH on the cells who have amplification of this oncogene called HER2, which is causing this intense brown staining on the surface of the cell. We see that the HER2 gene is amplified many times over. If you have 1 copy of HER2 gene, you have a single red dot like that. If you have 50 copies of the HER2 gene inside the cell, you see a cluster of red dots. Too many to count, but we estimate maybe 20 or 30 copies of the gene is present in one cell, which is outlined by 1 blue circle like that. This is the nucleus of 1 cancer cell. Similarly, in the signaling pathway that is affected by the Adenoma-carcinoma sequence, it starts off with EGFR on the surface of the cell and ends off with ERK1/2 close to the nucleus of the cell. So what the oncologist is interested in is whether there are mutations in the KRAS gene, NRAS, and the BRAF gene, which are also important in the development of cancer from polyps. So the IDELA system gives us a result within 2 hours where we put in the paraffin section as to whether there are any of these mutations that Dr. Fong may be interested in. So this brings a new era. Again, it's very handy. You don't have to wait 1 week for your results. Within 1 to 2 days, the results should be out. So basically, the treatment of colorectal cancer in a metastatic setting has gone beyond the simple application of chemotherapy. There are a lot of permutations many ways to skin the cat, which are now at Dr. Foo and the disposal of other oncologists who treat bowel cancers. And because we have the knowledge, we can exercise our knowledge for the interest of the patient. Cancer is like a box of chocolates. You do not know whether it's a KRAS, BRAF, NRAS, or MSI high status unless you test for it. And we have to use the right tools in order to seek out the answers that are needed to formulate our treatment plan for patients with metastatic colorectal cancer. That's my last slide. I shall now hand over to Dr. Foo. Thank you.
Hello, good afternoon, everyone. Thank you for taking time to attend these CME sessions. I will be talking about the updates in the management of metastatic colorectal cancer. Some of my talk will be essentially being covered by Brendan, but I'll quickly go through them. This is the scope of my talk. I'll be talking briefly on the overview of the management of colon cancer. And then I'll be talking about the biomarkers for colon cancer. And then lastly, I will talk about the update on the management of colorectal cancer. Overview. So for stage 1 to 3 in colon cancer, the most important modality of treatment is actually surgery. In stage 3 and selected stage 2 patients, adjuvant chemotherapy using oxaliplatin and 5-FU or just the oral capecitabine is given after surgery to reduce recurrence rates as well as to improve overall survival. For stage 4, the chemotherapy is actually the mainstay of treatment. However, some patients may require surgery or radiotherapy depending on the clinical situation. And this is usually decided in a multidisciplinary meeting called tumor board. And chemotherapy and targeted therapy has increased the overall survival as well as quality of life for metastatic colorectal cancer. If a patient did not have any treatment at that stage 4, the median survival is about 6 to 9 months. Now with all these new drugs that we have, the median survival has increased to about 3 years. Okay, this is where the overlap is. I'll be talking about the biomarkers in metastatic colon cancer, but I will go through very quickly. As Brendan has mentioned, cancer treatment has become more complex and we are using more targeted therapy. So we need to know what the targets are. So first, I will just go through very quickly the basic science, the epidermal growth receptor tyrosine kinases. Okay, so sorry, how come it goes so fast? Okay, so you can see that this is the receptors on the cells. They need a ligand called the ligand to stimulate them, and then there will be a cascade of reaction whereby they go to the nucleus to cause nucleus to divide and DNA to replicate. So along this, there are some genes that are there, which I will highlight again later. Okay, so sorry. Among the receptors in the cell surface, sometimes they can go short circuit and overexpress certain proteins. So one of them is the HER2 protein, which actually is also common in the breast cancer. It also occurs in colon cancer. So the drugs that we have, panitumumab and Erbitux, they attack the receptors at the tyrosine kinase receptors, so causing the cell to stop dividing, the cancer cells to stop dividing. So currently for colorectal cancer, there are 2 EGFR inhibitors. One is called cetuximab, the other one is called panitumumab. They are only proven to work in KRAS, NRAS, and BRAF wild type. All right. So if you have a KRAS or NRAS or BRAF mutant, these inhibitors will not work. Similarly, if you have a HER2 overexpressed, there are certain drugs like trastuzumab, pertuzumab, and this very new drug called trastuzumab deruxtecan, which is proven to be useful for colon cancer, HER2 expressing colon cancer. Okay, next is talking about angiogenesis. Okay, so for a tumor to grow from a small, like 1 to 2 mm, to be a larger tumor, it needs a lot of blood supply. And what it does is that it will secrete chemicals called the VEGF, ABCD, to stimulate the endothelial cells in the nearby blood vessels to supply it with blood vessels. And of course, the nutrient will come with it. So we do have new agents to target this VEGF pathway. So drugs like bevacizumab or Avastin attacks this ligand. Then we have this drug called aflibercept, which actually traps all the ligands. Another drug called ramucirumab, where it attacks the receptor. And the last drug called regorafenib, which attacks the receptor further down. These are small molecules. So these are currently the drugs that we have for attacking the VEGF inhibitors. Brandon has actually very elegantly spoken about the MSI. As he mentioned, 85% actually is chromosomal instability, and only 15% are due to microsatellite instability. As he has gone through very elegantly, I will skip this part of the talk on the mismatch pathway, which actually he highlighted that there's loss of control, and this is what happens, and then that's how cancer comes about. And we do know that immunotherapy is useful for this MSI deficient colorectal cancer, and the drugs that we have is pembrolizumab and nivolumab. So these are the biomarkers that we use. And then the next biomarker is actually the location of the tumor. As we broadly divide the colon into the right and left, at the splenic flexure, is anything before is considered right, and anything after is left. I'm sorry, let me just get back. Okay, so the embryonic origin of the tumor location, the left side is actually originating from the hindgut, while the right side tumors derive actually from the midgut, and the blood supply is totally different. And they have done the molecular subtypings, and they found that the left-sided tumors tend to possess genes expression that are characteristic of the EGFR inhibitor sensitive phenotype. And this is a result of one of the biggest trials called FIRE3, where they gave the same drug and they compared the results of the patient, whether they are right-sided or left-sided. For the right-sided, you'll notice that the overall survival was only 16.7 months when you're given cetuximab. Whereas the left-sided, the median survival is 36 months, which is 3 years. And 19.3 months is a lot of difference. And many studies have proven that this is so, that the left-sided tumors tend to do a lot better than the right-sided tumors. Okay, so I'll just talk about the update on the management of the metastatic colorectal cancer. What are the considerations first? Before that, I will just give a very brief history of a patient of mine who came from a neighboring country, Mr. A, who's a 66-year-old man with a family history of diabetes, hypertension, and he's also a hepatitis B carrier. He was actually very asymptomatic, but just went for a routine multiphasic examination with his GP in September 2017. At that finding, they found an elevated CEA at 13. He was investigated by a gastroenterologist and was found to have sigmoid colon cancer, and the scans showed that he had liver metastasis. He underwent an anterior resection, and subsequently, but post-op, his CEA was actually higher, went up to 75. And the PET scan showed that he has liver metastasis in both sides of the liver, both right and left. And he came to see me for further management. So what are my considerations? First of all, we look at the general health, age and fitness of the patient. We look at the RAS mutations. We ask whether is it right or left-sided, and then whether is it BRAF mutant, as well as whether there's MSI and HER2, and certain situations like when there's oligometastasis in the lung or liver, chemotherapy, surgery may be curative. So these are some of the considerations that I have. So what are the active chemotherapy agents in colorectal cancer? The backbone of all the chemotherapy drugs is this drug called 5-FU. If you look at this side of the screen, it actually inhibits this thymidylate synthetase, which indirectly will stop, which is needed for the DNA synthesis and growth. So there's also another pathway where it also inhibits the RNA as well over here. The other two drugs that we use together with 5-FU, one of them is called oxaliplatin, which is a platinum group, where they actually inhibit the DNA by forming DNA adducts. And the third drug is called irinotecan, which is a topoisomerase 1 inhibitor. I believe you all will remember that the topoisomerase are important for the DNA when it's supposed to be, when you divide, is supposed to wind and unwind. So this particular drug will inhibit the enzymes, and it will cause the DNA not to divide. So for first line and second line chemotherapy, we either use oxaliplatin with 5-FU or irinotecan with 5-FU in first line if they are fit. If they are elderly or unfit, we just give one drug, 5-FU, or just the oral form of 5-FU called capecitabine or TS1. However, for KRAS, NRAS, and BRAF wild type, we normally recommend the use of targeted drugs like cetuximab or panitumumab with chemotherapy for left-sided lesion in the first line. However, for KRAS or NRAS or BRAF mutant and right-sided tumors, we recommend chemotherapy with VEGF inhibitors. So these are the NCCN guidelines, which is essentially what I explained, all right? And then for unfit, they give only single drugs. So we go back to Mr. A. He is NRAS mutant, KRAS wild type, BRAF wild type, HER2 negative, and microsatellite stable. So because it's mutant, I gave capecitabine with oxaliplatin and Avastin. He underwent 3 cycles of chemotherapy, which showed very good response to on the PET scan. And he was also assessed by a few hepatobiliary surgeons who felt that the liver metastasis resection was possible. So he underwent surgery at the end of January 2018. He underwent a left hemihepatectomy, wedge resections of segment 5, 7, and 8 metastases. I'm sorry, I don't have the scans for this patient because some of them were done overseas. So anyway, for Mr. A, he continued with the 4th cycle of chemotherapy and he completed a total of 8 cycles. And he remained well until early part of this year when he was found to have elevated CA again, and investigation showed lung and liver metastasis. And he's currently on the 2nd line of chemotherapy. So first and second line, we have all those drugs which I mentioned. In third line, we have 2 new drugs. One is called regorafenib, which I alluded to earlier, which is a VEGF inhibitor. It also affects certain targets in the cells. The other drug is called Lonsurf. Lonsurf is actually the equivalent, works quite similarly to 5-FU, but in a slightly different mechanism. All right, so I'll move on to talk about special subsets of colorectal cancer. One of them, which Brendan mentioned, is the BRAF mutant. Okay, just a refresher. You follow the pathway, it will go down to RAS, then RAF, then MEK, and then it goes into the nucleus. So BRAF colorectal cancer, they are quite distinct. They actually originate in the serrated adenoma in the proximal colon. They are usually microsatellite unstable. They are hypermethylated. RAS usually wild type. And the patients are usually female with peritoneal and lymph node metastasis. However, this group of patients, the prognosis is extremely poor. First line, maybe 6 months, progression-free. Second line, 2 to 3 months. As I mentioned, they are very aggressive. Most GI oncologists will give 3 active drugs in the first line. And for the second line, we have drugs now combining EGF mutations, BRAF inhibitors, as well as a MEK inhibitor. So just to refresh your memory, from the receptor, it goes all the way down. We give inhibitors here, here, and here. So this was a trial that was presented this year, and they found that the combination of these drugs compared to chemo was much better. So a combination of, let me go back. A combination of the three drugs, encoforenate, binimetamide, and cetuximab, was much better than chemotherapy alone. And even two drugs was also better than chemotherapy alone. The response rate was 26% for three drugs, 20% for two, and control if it's only 2%, objective response. Okay, go on to talk about mismatch repair genes. First of all, I'll just introduce what is immunotherapy. Immunotherapy is also called a biologic therapy, a type of cancer treatment that boosts the body's natural defenses to fight the cancer. It uses substances made by the body or in the lab to improve or restore immune system function. As you all know, that there are many immune systems immune organs in our body, including the thymus, tonsils, the spleen, and the lymph nodes and bone marrow. Essentially, they protect us against invaders like viruses, bacteria, and cancers. The immune system is very tightly regulated. However, if your immunity is weak, you get infection. If you get too much, you get autoimmune disease. So, for example, when you have a tumor, the tumor will release antigens which will be captured by the dendritic cells. And the dendritic cell will go to the lymph nodes where it will sort of educate our T cells. And the T cells will be activated and they will kill the tumor cells. All right? But there's a lot of controls in our body because we don't want too much autoimmune disease. So some of the controls are in the receptors called CTL4 as well as PD1, PDL1. All right, these are one is from the cancer cells. PD1 is from the T cells. All right, so there are cancer killing effects, but there's also immune dampening effect. All right, so it's like the cancer telling the T cells, we are friends, you don't kill me. So we have new drugs. One of them is CTL4 called ipilimumab, and then PD1 inhibitors, basically pembro and nivolumab. And PDL1, atezolizumab and durvalumab, and there are a few others that are now in the market. So the immunotherapy was found to be very useful in melanoma, lung, as well as kidney cancers, very good responses. So what about GI cancers? They only found it for MSI high. I will just talk about a story of another patient called Mr. X. He presented in 2014 with a problem of change of bowel habit and bloating. He was found to have intestinal obstruction due to a descending colon cancer. He was operated, and the histology is a very rare. It's not the normal adenocarcinoma. It's a small cell neuroendocrine carcinoma of the colon. He had a PET scan which showed liver metastasis. He went through different types of chemotherapy, and actually after 1 year he wanted to stop the chemotherapy, and he asked for immunotherapy because at that time there were a lot of stories on skin cancer as well as on kidney cancer. So we decided at his own expense, we gave immunotherapy using pembrolizumab. So this was in August before we started. You can see that the liver started with all these black dots here is with the liver metastasis. About 4 months later, everything is clear. And this one is the color picture. These are the liver mets. And 4 months later, the liver here is clear. This gentleman is well as of February this year. His PET scan is still negative, coming to 5 years. From the time he had treatment. So, but immunotherapy doesn't work for all types of colon cancer, and this was in a trial which Brendan mentioned earlier, where they did it in colorectal. This is a study was presented in 2015. people with mismatch repair and those with proficient in mismatch repair, and another cohort where they have non-colorectal cancer with deficiency in mismatch repair, they compared. And you found that the people with MMR proficient, they do not respond at all, 0%. All right. Those with MMR deficient, there's a 62% response and the 92% control rate. And you can see the survival curve is a lot better with the mismatch repair deficient genes. Right. So, and this year they did a trial, they presented a trial in the first line for people with all these mismatch repair deficient patients, comparing immunotherapy versus the standard chemotherapy that we normally give. All right. And the result showed that the response was higher in the pembrolizumab, 43.8% versus 33.1%. And the survival was a lot better compared to chemotherapy alone. So very soon we'll probably be using that as the first line for people with MSI deficient. All right, so there are now two drugs, nivolumab and ipilimumab. Currently, there are a lot of trials that are ongoing, and we are waiting to see results. So in summary, colorectal cancer is very common. There are small increments in the treatment advances over the last decade, and treatment choices depend on the health, age, fitness, whether they are RAS mutant, whether there's BRAF mutant, HER2 or MSI, as well as the location of the tumor. My last slide is that I think a lot of you are primary care physicians, so prevention is actually better than cure. And primary care physicians have the privilege of educating patients on lifestyle changes, as well as advising patients to go for screening. As we all know, screening colonoscopy have been shown to reduce later stages of colorectal cancer. Thank you very much.
Myself, things have changed quite a fair bit in as far as systemic therapies for colorectal cancer is concerned. We've moved beyond just using chemotherapy. We are able to use targeted therapies and in a select group of patients, even immunotherapy. And through Brendan's help, we are also able to better select patients suitable for targeted therapies and immunotherapies. So I'm going to now move on to repeat the poll questions that we presented at the start of this session. And if I may request that you help answer these questions again, we'll give you about 30 seconds, 45 seconds for this. And we'll present the findings.
That's two.
All right. So question number 1 pertains to sidedness and prognosis. Left-sided colon cancers fare worse than right-sided colon cancers. My understanding from Dr. Fu's presentation is that the answer should be false. So we have about 3/4 of the audience answering correctly. Not to worry, the remaining quarter of attendees who's answered wrongly. I will not submit this to the SMC. The next question pertains to surgery being the main modality of treatment for patients with stage 4 colon cancer patients. I think Dr. Fu had mentioned that systemic therapy would probably be the mainstay. So most of the audience here have answered this correctly. And finally, this is actually a question posed by Dr. Brendan Pang, asking about what the most common inherited CRC syndrome would be. The initial answer from the audience before the presentations was FAP, but we now know that the correct answer should be LYNCH syndrome, and 2/3 of you have gotten this correct. Excellent. Okay, so now let's move on to the Q&A. I know some people have raised their hands as well, so I'll get to you guys as well. But let's go through some of the submitted answers online, or questions online. The most popular question here is, why should right-sided tumors have a significantly poorer prognosis? So I think maybe this question can be posed to Kian Fong.
Okay, actually, we really do not know, but as I mentioned earlier, 2 reasons. The embryologically, the one is from the hindgut, one is from the midgut. So I guess there might be some differences, number 1. Number two, they have done the molecular characteristics of the right and left. And we found that on the left side, they tend to express more the KRAS, NRAS, as well as BRAF. They are usually wild type. So they are more amenable to treatment using the EGFR targets like nitumumab and cetuximab.
Okay. So next question I think we can pose to Brandon. It's one of the second most popular questions regarding cost of tests. I think here, I presume, is a cost related to MMR testing or MSI testing. Brandon?
Yeah. Okay. So basically, the cost of these tests usually is in the 3-digit range, maybe about $500 to $600. In the restructured hospitals, it may be slightly cheaper because of government subsidies and inpatients. So for one test, we can expect to be quoted about maybe $500 or $600 or thereabouts. So to be aware of the exact cost, please contact your sales rep or your hospital laboratory representatives, who will then quote the cost to you. And then it's an add-on cost after the surgery is done or after endoscopy is done. So the cost is not bundled into what the patient is going to pay for colonoscopy and just a basic histo report. It's an add-on cost on top of that. So make sure that it is ordered appropriately for the patient with the right stage of disease, and that the patient can maybe get reimbursement from the insurance or wherever before you sort of, quote the cost to your patient. Yeah, thanks.
So, Brandon, another question for you, posed by Mr. or Dr. Bhaskaran, asking about doing MMR testing for patients and specifically testing the polyps with the intention of identifying if there is an inherited risk for colorectal cancer. Your thoughts?
Yeah. So there are two kinds of serrated polyps. I did not go into this during my lecture. So one is called the sessile serrated adenoma, and the other is called the traditional serrated adenoma. So the former is the one that is found on the right side, has the promoter hypermethylation in half of them. Half of them do not. So it's not every single right-sided serrated polyp that has this MSI in its phenotype. No, not true. It's only about half or slightly less than half of them. And then you can do a concurrent BRAF test, immunohistochemistry, together with immunohistochemistry for MMR. And with BRAF positive, then that fits in with the sessile serrated polyp that has an increased chance of becoming an MSI high colorectal cancer. So basically, you do not need to include this test with the diagnosis of the polyp. The diagnosis of the serrated polyp can be made without these additional tests. So the diagnosis itself confers the increased risk of developing a colorectal cancer earlier and should already prompt enhanced surveillance depending on your local medical guidelines for endoscopy. So you may want to increase the frequency from 3 yearly or 5 yearly to, for example, 1 yearly. If you find a sessile serrated polyp or a sessile serrated polyp with progression or some unusual features such as mixed dysplasia. Yeah, so I hope that answers your question.
Okay, so I have a question here. I think we can pose this to Dr. Fu. Why does MSI high colon cancer carry a better prognosis in a stage 2 setting, whereas it carries a worse prognosis in the metastatic setting?
Okay, this is actually in the days where we don't have immunotherapy with the natural history, because they in early stage, they usually, once you remove it, surgery is the mainstay of treatment. However, once you have spread, and a lot of them are related to BRAF, which is also very aggressive, so the prognosis is worse.
Okay, so bearing this in mind, since it can influence treatment decisions, what is the concordance and discordance if we were to use the PCR test for MSI testing versus immunostains for MMR? Brandon?
Okay, allow me to share screen. Okay, so this is a slide describing one of the biggest studies done to date with thousands of samples published by Bartley and company. So if you look at the top 2 rows, where by PCR, the MSI is high in about 102 cases, there's a concordance of IC loss of expression almost 90% of the time, about 88%, high.
Never heard it before, don't understand.
when the PCR is normal, the IHC is concordant 99.8% of the time. So for this suggests that the PCR is slightly more sensitive to about maybe 12% of the time for picking up true MSI phenotype when the IHC says it's normal. And reason why? Because we're only doing IHC for 4 proteins, but there are other proteins like MLH3 and EMS1 for which there are no reliable, robust commercial antibodies for. So this explains why, and some of the mutations do not result in the loss of expression. You may have an expression of a protein that is functioning suboptimally, but this suboptimal functioning protein that is still expressed may cause the microsatellites to shift and unravel and become unstable. So that's why I would still say that PCR is more sensitive. However, the PCR cannot tell what is the pattern of loss. Is it methylation driven, or is it inherited in the germline? So doing both tests together might be the best solution. You get the best of both worlds, and you get a more certain diagnosis of the microsatellite stable or unstable phenotype of the tumor. Hope that answers the question. Yeah.
Okay, so along a similar vein, Brendan again, talking about MSI testing, when the tumor is MSI high, what proportion of the tumor will be so, and what happens to the rest of the tumor that's not MSI high?
Okay, so this is a question from Stephen. So when MSI is diagnosed, the whole tumor is MSI high. It's not, there's no clonal heterogeneity for MSI high because it's a very early initiating of event. It is present in every single cell of the polyp. So when it's positive, even after the clonal, the tumor becomes invasive and subsequently shows clonal divergence, all the clones should also be MSI high. Maybe a subset of them may go on to develop a further loss of other genes or other proteins, but they should all be MSI high. Hope that answers Stephen's question. Yeah.
Okay, so we've kind of covered the molecular diagnostics and influence in therapy selection. Maybe we talk about the treatment now and move on to Kian Fong. Some questions asked about use of immunotherapy and specifically pembrolizumab causing autoimmunity. Autoimmune is used. Your thoughts?
Yes, definitely. That's one of the problems that we do see in about maybe 20% of our patients. They do have autoimmune problems. Most common things like thyroid. They get autoantibodies to the thyroid, so hypothyroidism. They also have antibodies to the lungs. You get pneumonitis, as well as hepatitis and autoimmune. Even if we get patients with steroids problem, autoimmune, the adrenal, they get autoimmune attack on the adrenals, so causing a low cortisol level, and various other different places may be affected. I have a patient who actually had autoimmune, almost like a Graves' disease. Sorry, not Graves. Sorry, like myasthenia gravis. So many places, but so we have to be actually actively looking out for these problems and referring to the right subspecialty colleagues to help us co-manage when they have these autoimmune problems.
So another therapeutics question from Dr. Kwek. What the reason is behind using Avastin, bevacizumab in right-sided colon cancers, but not left?
Oh, that's based on the trial, the phase 3 trial, and they found that patients with VEGF on the right side, they tend to do better than using, somehow those on the right side, they do not respond so well to the panitumumab or cetuximab.
Okay, so let's see. Anyone had raised their hands and wanted to ask a question still? Let's have a look. Okay, so those who had wanted to raise their hands or did raise their hands are no longer raising their hands. That gives us the opportunity to have one more question, because I'm quite keenly aware of running over time now. The last therapeutics question, I think we can float to Dr. Fu. Does resistance develop to VEGF inhibitors and immunotherapy?
Definitely yes, they do. So usually after a while, they may not respond.
Okay, with that in mind, let's move on to close the Q&A session. Thanks everyone for your participation. Okay, so if you have any further questions that we've not been able to answer, feel free to email any of the speakers directly. And for those of you out there who have certain interesting topics you have in mind that we haven't yet covered since the start of our series in April, please feel free to email us as well with your ideas, and we'll try to accommodate that if possible. Then a little bit on what we have planned for you in the coming month. So the next CME will in fact be this Saturday, where Dr. Khoo Kay Seong and Dr. Esther Chua will be presenting to us on the advances that have been made in the last 30 years as far as breast cancer treatment is concerned. Then Dr. Richard Quek and Jeremy Chow will be talking about cardiac toxicities of treatments. This will be followed on 9th July by our regular tumor board, and then through to middle of July, where again there'll be a breast cancer talk presented by Dr. Si Hui T and our radiation oncologist, Dr. Lee Ko An. So please try to take some time out to join us on these occasions. Okay, with that in mind, I'd just like to thank everyone again for joining us this afternoon. Sorry, we're a little bit over time by 10 minutes. See you all the next time. Take care, everyone.